Welcome, everybody. Today we are going to learn about extrapulmonary NTM. I'm Amy Lietman, president of NTM Info and Research. I will be your moderator for today. Many people don't know that you can get NTM infections outside of the lungs in skin and soft tissue as well. So today we're going to learn more about that part of the disease. There are patients among us who have them, and luckily they can find us for support as well. And I think it's important that we all learn about it so we can help support them. Our guest speaker today is Dr. Elisa Ignatius. She's an assistant professor of medicine in the divisions of infectious diseases and clinical pharmacology and the program director for NTM and bronchiectasis at Johns Hopkins University. Dr. Ignatius received an undergraduate degree from Columbia University, a doctor of medicine from Emory University, and a master of science from the London School of Hygiene and Tropical Medicine. She completed her internal medicine training at Emory University, followed by a postdoctoral fellowship in infectious diseases and clinical pharmacology at Johns Hopkins School of Medicine. She has extensive experience in caring for patients with non-tuberculous mycobacterial infections, tuberculosis, bronchiectasis, HIV, and other infectious diseases. She's a member of the Tuberculosis Transformative Science Group with the AIDS Clinical Trials Group, ACTG, and serves as a protocol pharmacologist on several clinical trials. Her research interests focus on treatment optimization strategies for mycobacterial infections, NTM and TB, including regimens of novel and standard drugs. So we are very pleased to welcome you here today. After the session, we will be doing Q&A. So during the session, you can type your questions into the Q&A box and hit send. If you want to send it anonymously, you just hit the send anonymously box. We are prioritizing the questions about extrapulmonary. Some of you may have pulmonary questions, but we have to get to the extrapulmonary first. We do have a fair bit of clinical research and some industry on today as well. There's a lot of interest in this topic. So we're going to try and get to everybody's questions, but we do want to answer all the extrapulmonary questions first. We'd like to thank our supporters, Insmed, ICU Medical, Mankind, Paratech, and Spiro Therapeutics for supporting World NTM Awareness Day as you've gone through the month of August. You've attended many of our webinars. This is the fourth and final in the World NTM Awareness series, and we are delighted that Dr. Ignatius is taking up the final leg and bringing this wonderful month home to a close. We'd also like to thank all of our partner organizations for helping to amplify the message of World NTM Awareness over the month. They've done a fantastic job. The message has gone worldwide. We've seen it in many languages around the world, and we couldn't have done it without all of their help. So thank you very much. Also, if you are an extrapulmonary NTM patient, or if you are the caregiver for a patient with extrapulmonary NTM, we do actually have a support group specifically for you, and we are having a support group meeting tomorrow, Friday, August 23rd at 3 p.m. You can ask for the meeting link by emailing us at ntmmail@ntminfo.org. So I hope if you need support, you will please join us. We are here to help. Dr. Ignatius, welcome. Thank you so much for being here. We are looking forward to the presentation, and please take it away.
Wonderful. Thanks so much, Amy. So let me just go ahead and share my slides here. Okay. All right, so I'll get started. So just as brief disclosures, I do receive research funding from NIAID and participate as a site PI or co-investigator in a number of clinical trials sponsored by these entities, but receive no direct personal payments from any of them. So we're going to try to cover in a pretty short amount of time a very complex and very diverse disease entity, which is extrapulmonary non-tuberculous mycobacterial cases. So I will try to review the epidemiology, pathogenesis, and diagnosis, explore what is similar and what is unique about treatment of extrapulmonary cases, and then highlight some of the management challenges which really are shared across the NTM spectrum. As many of you are likely already aware, NTM cases in the United States and around the world are on the rise. And this has been shown in study after study after study. This seems to be outpacing increased diagnostic awareness, increased laboratory capacity to identify NTM. So this seems to be a true epidemiologic rise in the number of cases that we're seeing. And there's a number of different theories, hypotheses about why this might be happening. Largely, most of these theories do center around climate change, increased water coverage, certain adverse weather phenomenon, things like that. So we are seeing this in many different contexts. And so this is likely going to be something that we as clinicians do need to continue to be aware of and have a very sort of up-to-date and evolving perspective on when it comes to the clinical management. So just briefly, before we dive into extrapulmonary specifically, I think it's just important to briefly touch upon the diversity of non-tuberculous mycobacterial species in general. So as many are likely aware, these have historically been split into rapid growers, so those that grow in culture in fewer than 7 days, versus slow growing species, which take 7 or more days to grow. And you can see that split here on this chart. Many, if not most, of these organisms are capable of causing pulmonary NTM infections, and I've highlighted that on the upper right. But there are certain subspecies that do have a predilection for causing certain site-specific NTM infections, and we'll dive into many of these in greater detail. In terms of the diagnostic criteria, for pulmonary NTM, this is quite well established. It doesn't mean it's always easy to diagnose pulmonary NTM infections. There are lots of delays oftentimes, but we know that patients need to have supportive clinical symptoms. So that's cough, shortness of breath, hemoptysis, coughing up blood, or sometimes these systemic fevers like fevers, night sweats, unintentional weight loss. They need to have supportive imaging on CT scan, and that could be nodular or cavitary opacities or multifocal bronchiectasis. And then they need to meet microbiologic criteria. So at least 2 expectorated sputa that grow NTM, or a deeper bronchoalveolar lavage, or a lung biopsy that shows supportive pathology. For extrapulmonary cases, diagnosis can be really, really challenging. And there's a number of different reasons for that. So one of them, I think, is well highlighted by the upper right figure, which was taken from a paper describing a fairly large outbreak of a rapid grower species. And what it's trying to relay here is that not all patients who are ultimately thought to have this extrapulmonary infection were diagnosed in the same way. So some of the patients had a positive culture, and that's the top circle in the Venn diagram. Some of them had positive smear microscopy, so where you get the specimen and you're looking immediately to see if there's visible bacilli present. So that was the positive bacilloscopy. And then some patients had granulomas. So when they took the pathology from the resected tissue, they could see granuloma formation. But you can see that some patients just had 1 or 2, a few patients had all, but that was really the minority. And so this is just to highlight that if the clinical suspicion for extrapulmonary non-tuberculous mycobacterial infections is present, is moderate to high, you really need to have all these different types of tests that are done on the specimen at the site of disease in order to have the best chance of actually diagnosing these cases. On the bottom right, I've highlighted, just some of the types of infections that we can see and the number of different species that are capable of causing these different infections. So we've got an entity that's challenging to diagnose with our traditional diagnostic tools. We've got a very diverse array of species. We've got a similarly diverse number of sites, and that's highlighted on the left-hand side. So these can be focal infections that develop after surgery at that site. They can be disseminated infections that can actually be circulating in the bloodstream and deposit at different areas within the body. They can be associated with prosthetic joints, with contacts. They can be in the lymph nodes. So there's just so many different ways in which extrapulmonary NTM cases can present, which again means that the clinical suspicion needs to be high so that the right diagnostic tests are ordered and performed so that hopefully that diagnosis can be secured. And just to also kind of underscore the difference between local infection versus disseminated infection, because I think that that's important, particularly for patients who are more familiar with the pulmonary manifestation of NTM. So it is extremely uncommon. One of the main points I want to get across is it's extremely uncommon for isolated pulmonary NTM infection to disseminate and spread throughout the body, period. There have to be certain conditions met in order for that to be possible. And usually that comes in the form of either an innate immunodeficiency or an immunodeficiency that's caused by somebody being on very heavy-duty immunosuppressive agents. So this is not something that happens readily. The lungs are very good at containing these NTM infections in the vast majority of people. But in rare cases, when those conditions are met, when there is an intrinsic or a sort of externally enforced immunosuppressive process going on, this is possible to happen, that a pulmonary infection would be the original kind of portal of entry, and then the infection could spread throughout the body to other sites. What can also happen is that such a huge burden of infection is introduced into the body through a surgery or other procedure that's not done in sterile conditions, that it exceeds the body's ability to kind of clear what would usually be a pretty innocuous, environmental organism. And when that burden is just profoundly high, even with that patient having a fairly normal immune system, there are cases in which the infection can circulate in the body. But most of the time, in a person who has a normal immune system, if they do develop a post-operative infection, for example, that infection stays right at the site of the original procedure or surgery. So exploring some of the post-procedural kind of infections and outbreaks that have been described, because these over the last many years have had a lot of coverage in the press, and for good reason. These were sort of major events that have been tracked very closely and have resulted in pretty major changes in the way some of these procedures are done. So on the left-hand side is a well-known outbreak that occurred after cardiac surgery. And these were outbreaks of Mycobacterium chimera, and they were ultimately found to be associated with the heater-cooler units that were used during these cardiac surgeries. And these patients are mostly described within the United States, but have been also detected around the world. There were some sites where it was particularly common, but there were multiple different hospital systems where this occurred. And as you might imagine, there were often, in many of these cases, a considerable diagnostic delay. And so one of the changes that kind of happened after this is anyone who's undergone a procedure where after the fact it's been found that the device or the materials that were used could have been implicated in such an outbreak, there's now mechanisms in place to send out letters to them, as well as put flags on their medical chart, so that if they're coming in, months to years later with a somewhat mysterious, type of infectious syndrome, that will flag for clinicians that this is somebody in whom this type of unusual infection should be suspected. There was also in Brazil, and this is on the upper right-hand side, an epidemic, an outbreak of post-surgical infections, over 1,000 suspected cases, actually. And these were ultimately linked to video-assisted surgery. And what it was thought was that a commercial sterilizing solution was not sufficient to sterilize the material that was being used. And so it was a sort of failure of sterility. And again, a number of changes were made in response to this. This was many years ago at this point, in order to prevent such an occurrence from happening again. We're also seeing on the bottom right-hand side, this is highlighting that in the United States, and again, also demonstrated elsewhere in the world, that with cosmetic procedures, particularly those done outside of a traditional hospital setting, that we are finding a number of cases of extrapulmonary NTM infection. And so some common scenarios that we're seeing, I've taken care of many of these patients myself, after they've had fat graft procedures or other procedures that are sort of labeled as being low risk, but unfortunately they, for this medical tourism, are sometimes done in clinics, outpatient clinics that really don't have the same robust sterilization protocols in place that a hospital type of setting would. And so these patients are traveling often great distances to get these procedures done in these sort of outpatient clinics, and then they're returning home to wherever their home base is, home state. And so again, that contributes to some degree of diagnostic delay, but I think thankfully, for better or for worse, a lot of clinicians are now aware of this phenomenon. And when a patient comes in after one of these cosmetic procedures, has a sort of, indolent infection that's not readily responding to traditional antibiotics, they're very quickly starting to collect the necessary types of cultures and microscopy that would be needed to diagnose an NTM infection. Prosthetic joint infections are also very well described as being associated with NTM. Thankfully, among all the prosthetic joint infections that occur, NTM are a very uncommon cause. And so I think that that's another important thing just to underscore, because so many people do undergo prosthetic joint infections for various causes. So these post-operative infections can be local, or they can be in the setting of an already widespread disseminating infection that then sticks to the prosthetic material. So they can sort of be primarily infected or secondarily infected from a circulating NTM infection. Um, Most of these cases sort of started to manifest with signs and symptoms of infection 3 or more months out from surgery. And so again, the clinical suspicion has to be high in order to make these diagnoses in a efficient manner. In the vast majority of cases, the prosthetic material does need to be removed in order to have a good chance of eradicating this infection. And often these patients do end up having to undergo multiple staged kind of removal, attempted sterilization, and then reimplantation of the hardware once we're confident that the infection is gone. And the reason for this is that Mycobacterium abscessus, for example, is notorious for this, but Mycobacterium in general like to form biofilms on prosthetic material, and that can be very, very difficult to eradicate if the prosthesis is retained within the body, which is why often it needs to be removed, and as I said, sort of then covered with a long period of antibiotics before definitive reimplantation. On the right-hand side was just from one, case series, certainly not exhaustive of all the cases that have been described, but showing that Mycobacterium fortuitum was among the most common infecting organisms for prosthetic joint infections, followed by Mycobacterium abscessus. A fairly classic form of extrapulmonary NTM is post-traumatic tenosynovitis. And the most classic kind of infecting subspecies is Mycobacterium marinum. And so this has historically been associated with fish tanks. So in one case of 63 cases, 84% of these cases were related to fish tank exposure. In another series of 136 cases, this had a number of patients who were fishermen. 61% were associated with puncture wound from a fish bone or a fish fin. And so Mycobacterium marinum infections tend to cause these granulomas and nodules to form in the subcutaneous tissue. Generally, if these infections are identified in a timely manner, antibiotics can be started. Sometimes debridement or surgical operative debridement is necessary, but usually 3 to 4 months is sufficient to cure these infections. Of course, every patient is different. If there's immunosuppression or if the infection starts to go down into the deeper bony structures, that can sometimes end up extending the treatment duration. But in general, these infections tend to be quite curable after a few months of treatment. And just at the bottom, highlighting from the case series of 136 patients, again, the point that I already made, which is that the clinical suspicion must be high. So in this case series, where it sounds like the vast majority of people fit kind of the classic host, right? They were fishermen, they worked with these, fish, their hands were in the water all the time. Still only about 42% had positive cultures, 36% had the smear microscopy that was positive. So really needing to have all of the data in order to cinch the diagnosis. So another form of extrapulmonary NTM infections that affects the skin is Buruli ulcers, which are caused by Mycobacterium ulcerans. So this is a specific subspecies of Mycobacteria that is endemic to parts of the world highlighted on the bottom right map. And so this is an environmentally acquired organism. There's a number of different modes of transmission that are thought to contribute, and that mode of transmission may differ depending on the part of the world that we're talking about. But it causes lesions like the one on the upper right. So these are superficial abscesses, but they can, if left untreated for a while, be quite painful and sometimes take quite a long time to resolve. Surgical debridement used to be sort of central to the management. Now, with combination antibiotic therapy, surgery often can be avoided. But again, it does take a number of months for these infections to resolve. Thankfully, there is also some drug development going on in this space to try and give newer, very effective short course drugs to eradicate this infection. NTM-associated keratitis is another very well-described extrapulmonary manifestation. Risks are really anything that disrupts the corneal epithelium, so surgery, foreign body injury, wearing contacts. This has been very well described after receiving LASIK surgery. Most cases are caused by rapid growers, so Mycobacterium fortuitum, Mycobacterium chelonae. And though these cases generally, can be cured and folks do well, there are some challenges. The eye is a sort of privileged site that sometimes our systemic antibiotics, be they oral or IV, don't get into very well. We do have some that penetrate into the eye well, but that is why often for these instances of keratitis, topical therapy is needed. Topical amikacin is often recommended in these cases, but one challenge is that, as anybody who's taken amikacin or is familiar with the NTM treatment space knows, amikacin is a pretty toxic drug when given intravenously. It's also a pretty toxic drug when given topically. And so it's not uncommon that patients have issues with tolerability, and it can cause just a lot of inflammation on the eye surface. Surgery is often necessary in these cases as well. Another very well-described NTM manifestation extrapulmonary is lymphadenitis. So it's actually the most common form of NTM infection in children. And it looks kind of like the picture on the upper right, although this is actually an adult patient. It is most commonly a single lymph node that's enlarged and infected, but it can be multiple. And in pediatric cases, at least, they're not, these patients are not always immunocompromised. So it can actually happen in pretty immunocompetent or normal immunologic children. And in adults, though, it does tend to be more in patients who have some form of, again, intrinsic or sort of externally caused immunosuppression. And on the right-hand side is an image just from the outside where you can see the enlarged lymph nodes, and then that same patient with a cross-sectional CT, you can see the area that's sort of rimmed, as the arrow pointing to it, but it's sort of rimmed in white and it's darker on the inside. The most common species in one case series were abscessus, Mycobacterium homophilum, Mycobacterium fortuitum. And again, on the bottom, it again highlights what I've mentioned now a number of times, which is the challenge with diagnosis. So really need the smear microscopy, culture, and pathology in order to make this diagnosis. Another form of extrapulmonary NTM is disseminated BCG. So BCG is an attenuated live strain of the Mycobacterium bovis, which is what could cause tuberculosis in cows, as you might glean from the name. And BCG has been given for decades to children to prevent tuberculosis. It's particularly good at preventing the most devastating manifestation of TB in children, which is tuberculosis meningitis. So it's an entity that we have a lot of collective experience with around the world. But it's also very effective in treating bladder cancer, particularly when it has not yet invaded through multiple layers of the tissue, and it's more just kind of on the superficial structure inside of the bladder. And so this BCG treatment is where basically you just instill BCG into the bladder through a catheter, and then it topically kind of treats this bladder cancer. So it's very effective, fairly well tolerated, but in rare cases, though it has been very well described, it can cause local abscesses, local infections, and then it can also disseminate throughout the body and cause what we sort of informally call BCGosis. So the CT scan of the lungs in the middle there is, you can see throughout, there's these very fine nodules, and this is a patient who was receiving intravesical BCG treatment for bladder cancer, and it sort of spilled out of the bladder and into the bloodstream, ending up in the lungs. On the left-hand side is one case series of 282 patients who did develop this disseminated BCG infection, or a local, more invasive BCG infection in the genitourinary system. So just highlighting that there can really be all these different ways in which BCGosis can kind of manifest. So in patients who are receiving intravesical BCG treatment for bladder cancer, this is something to be mindful of if they were to develop any signs or symptoms of an infection and the diagnosis wasn't, easily made with traditional diagnostic techniques. So I touched upon the fact that immunosuppression is often a necessary precondition to develop disseminated mycobacterial infections for many patients. then I was also kind of highlighting instances of extrapulmonary infection where it was really just because they had a procedure that inoculated a high burden in that moment and it stayed fairly focal. But just to kind of expand a bit on the immunosuppression piece of this extrapulmonary NTM spectrum, it's not all identical. So as is highlighted in this graph or in this table here, a number of different immunosuppression conditions clearly associated with increased risk of both pulmonary and disseminated. But sort of the balance between pulmonary versus disseminated depends quite a bit on the immunosuppressing condition that we're talking about. So, HIV is associated very highly with disseminated Mycobacterium avium complex in particular, but disseminated NTM infections, versus being on chronic steroid therapy for a respiratory disease, which is really most strongly associated with a pulmonary NTM infection. But a lot of these other conditions, stem cell transplants, hematologic malignancies, solid organ transplants, being on a biologic for immune-mediated inflammatory disease, that balance differs kind of immunosuppression condition by condition. So in these disseminated cases, again, a wide spectrum of disease, and I've just highlighted 4 kind of illustrative examples here. So on the bottom left is a young girl. This is now a very well-known case for reasons I'll circle back to in a few minutes, who had cystic fibrosis and underwent a lung transplant, and unfortunately post-transplant developed a disseminated Mycobacterium abscessus infection. So it was at the surgical site, but also other sites within the body. Followed by then a young man who had HIV and developed disseminated Mycobacterium avium complex, so disseminating within the bloodstream, and then formed an epidural abscess, an abscess over the spine, as well as spinal bone infection, spinal osteomyelitis. And then the 2 on the right-hand side are 2 cases of patients in their 50s with inflammatory arthritis. One was rheumatoid, one was seronegative, and who had both been on various immunosuppressing agents, abatacept, prednisone, tofacitinib, methotrexate, and developed multiple skin lesions that were found to be growing Mycobacterium chelonae. And so this is also a very well-described phenomenon. So in each of these patients, fairly extensive disease, multiple sites, presumably was circulating in the bloodstream at one point, even if that wasn't detected because there were multiple sites involved. That's the presumption. And then just focusing for a moment on patients with HIV, because I think that historically this was a really big part of how we came to understand treatment for disseminated NTM infections. So in the pre-antiretroviral therapy era, developing disseminated MAC was almost an inevitability the longer that somebody lived with HIV. And as you can see on the left-hand side, that's a figure that depicts the different opportunistic infections that patients with HIV were susceptible to. So at highest sort of level of immune strength, Kaposi sarcoma was something that was seen sort of as the immune system declined. You'd start to see some non-Hodgkin's lymphoma, pneumocystis, and then once the T cells dropped below 50, that was the general threshold, then you started to see these real opportunistic infections like Mycobacterium avium complex, cytomegalovirus infection become a very, very common. On the right-hand side is sort of the probability of NTM-free survival. So at the beginning of this surveillance period, nobody had known disseminated MAC infection. And then when you got to sort of 42 months, over 50% of people had evidence of a disseminated MAC infection. And then also kind of underscoring a similar finding in the middle was that one autopsy study, again, this is many decades ago now at this point, found that 43% of patients with HIV at the time of autopsy had evidence of disseminated MAC based on lymph node samples or other organ samples. Thankfully, in the post-antiretroviral era, this observation, this phenomenon of disseminated MAC being incredibly common in people with HIV has just disappeared. And it's been really, really incredible to see. And so this has been, replicated in multiple cohorts across the country, across the world. Once patients are on highly active, multi-drug antiretroviral therapy, this is really not a concern anymore because their immune system so quickly and durably reconstitutes, becomes healthy again. Because I know that this may be a question that folks have, I haven't looked in the chat yet, but rheumatologic conditions and the drugs that we use to treat them have been associated, some more so than others, with NTM infections. And while the majority of these NTM infections are pulmonary, there are a number of cases, and I mentioned two that I pulled from the literature, of extrapulmonary cases associated with use of some of these agents to treat rheumatologic diseases. So the American College of Rheumatology does have some guidance on how clinicians should handle and new NTM infections for people who are on some of these drugs. There are certain classes that are seeming to be recommended more than others, but I would say that this is still very much an evolving area of medicine as more and more people are on these immunomodulatory therapies, on these biologics to treat these different rheumatologic conditions, which, if any, are more or less associated with pulmonary NTM, with disseminated NTM. And so again, I think that this is still an area of science that's evolving. I've glossed over kind of the innate immune deficiency category a bit, and this is by no means an exhaustive kind of treatise on this very complex subject. But I've just highlighted here some of the more common immunodeficiency conditions that have been associated with recurrent NTM or more severe NTM disease. These include common variable immune deficiency, or CVID. There's also a number of autoimmune conditions which have been associated with increased risk of NTM infection. Profound idiopathic CD4 lymphopenia has also been associated. And one kind of case series that underscored this was a case series of central nervous system involvement with these non-tuberculous mycobacterial infections. And so I just pulled two of the cases out from this case series. So one was a young man with nuclear factor kappa B essential modulator, or NEMO, deficiency. Another was a young woman with anti-interferon gamma antibodies, both of whom had developed disseminated MAC into the brain or the central nervous system. And so, as you can imagine, these are very difficult cases to treat. But any patient that were to develop a disseminated NTM infection that went to the brain without there being something profound that was given to them to weaken their immune system really needs a thoughtful and thorough immunologic workup for these rare, but nonetheless very well described immunodeficiencies that have been associated with severe NTM infections specifically. So touching briefly on the management of these difficult extrapulmonary cases. So my broad comment is that extrapulmonary NTM infections in general have similar drug susceptibility profiles, similar combinations of drugs that we use by comparison to pulmonary infections. Debridement is often required, which I think is something that does distinguish these extrapulmonary cases from pulmonary cases. In many cases, debridement is essential in order to have a chance of curing this infection. And so I've just highlighted here some of the many drugs that we use. Again, I could talk about any of these in greater detail if there are questions, but my broad comment is that the drugs are similar, the regimens are similar, the durations can be highly variable, and I'll circle back to that in a moment. Just a couple drugs that I'm pulling out here to talk about in slightly more detail. Clofazimine is a drug that we do use in complex pulmonary NTM infections, particularly when people are treatment refractory, so not responding to the standard treatment. And we do use them very often, I would say, at least in our practice, for the treatment of extrapulmonary NTM infections as well. The sort of level of evidence that's in the literature is not tremendously high, but we do think it works fairly well based on anecdotes in some of these case series. As anybody who's taken clofazimine knows, it does get into the skin and soft tissue quite well. It can cause this discoloration from the dye deposition. And so the thinking also is that for these non-pulmonary disseminated cases, particularly in the skin and soft tissue, that clofazimine may actually achieve fairly high levels at those sites of disease, which could enhance its effectiveness in treating some of these infections. Omadacycline is another kind of newer drug, which we are increasingly using often as first-line treatment in our program when we can access it. And again, there's not a randomized control trial showing that the addition of omadacycline versus not in treating these extrapulmonary cases adds additional benefit. But our anecdotal evidence, as well as the emerging, I would say, case reports, case series that are out there, also do suggest that omadacycline has a role in treatment of these extrapulmonary cases. Again, not going to do an exhaustive kind of review of this, but side effects from treatment of these extrapulmonary cases are quite common and can be severe. But close monitoring and some simple mitigation strategies can sometimes help make these drugs and combinations of drugs more safe and more tolerable for patients with extrapulmonary NTM. So again, highlighting here some of the more common drugs we use, some of the adverse reactions, and the monitoring that we recommend. And because, I know that this is always a hot topic of discussion and something that I think has really had an important role in some extrapulmonary NTM cases is antimycobacterial bacteriophage treatment. And so you may recognize the image that's shown here from an earlier slide. This is that same young girl who has cystic fibrosis. This was the first published case of use of bacteriophage treatment for for mycobacterial infections in general, for non-tuberculous mycobacterial infections, I should say. And it did appear to be quite beneficial. So you can see the images on the left-hand side. This was pre-phage. On the right-hand side was post-phage. You can see the PET CT on the bottom right. So it went from a bunch of bright areas of hypermetabolic activity to much calmer. And then a similar image on the upper right-hand side as well. And where I think it was last year, there was also a case series of the use of mycobacterial phage treatment in patients who had multi-drug resistant mycobacterial disease. These were not all extrapulmonary cases, but a number of them were. So I think that this is, in very challenging cases, something that some clinicians are reaching for. Unfortunately, it's not a technology that as of yet can be readily scaled, to be accessible to everyone. It takes quite a bit of work and time to find a match for that specific infecting isolate. But is nonetheless something that is out there, and the data can continue to emerge. I also wanted to mention just something that I think is important and is fairly unique to these extrapulmonary NTM cases, which is this phenomenon of immune reconstitution inflammatory syndrome, or IRIS. So IRIS is really classically associated with HIV, but we do see it at times in patients who are immunosuppressed or immunodeficient from a different cause and develop an NTM infection. And basically what IRIS is when there's this kind of exuberant inflammatory response that is triggered by the reconstitution of the immune system. So in people with HIV, historically, this was when they got started on effective antiretroviral therapy. Their immune system started to recover, and it was able to more vigorously attack this opportunistic pathogen that was causing the person to feel sick. In somebody who's perhaps immunodeficient because of being on a medication, sometimes what we see is that if that medication is then stopped or the dose is reduced to help the person fight off the infection, sometimes as the immune system wakes up a little bit more, it can again attack that pathogen very aggressively. And sometimes that weakening of the immune system and aggressive attack against the infecting organism can make somebody feel sicker temporarily. And depending on the site of the body where this is happening, it can actually sometimes be dangerous. So if that inflammatory response is happening in a part of the body where there's not a lot of room for inflammation to expand, that can sometimes end up compressing on some of the structures, that are affected. So just wanted to mention that, mostly kind of for teaching purposes, that this is something more unique to immunosuppressed patients, and something we do sort of see more with these extrapulmonary cases. So treatment duration, as I kind of alluded to before, it really depends. So for isolated skin infections with Mycobacterium marinum, there's lots of case series of 3 to 4 months being sufficient. For prosthetic joint infections, it tends to be at least 6 months, but sometimes it can be quite a bit longer, depending on all these other variables that might be at play. For vertebral osteomyelitis, so bone infection of the spine, there's no consensus. And again, treatment duration can be highly variable, but can end up being quite long in many cases. For people with HIV and disseminated MAC, Generally, the guidance is at least 12 months, but also immune reconstitution needs to happen during that period of time in order for treatment to be stopped. So just, again, this could be a whole talk in and of itself, but treatment duration for these extrapulmonary cases is highly dependent upon the host, the pathogen, the drug susceptibility pattern, whether or not there's prosthetic material present, how the patient tolerates the drugs, all these different variables. And the last thing I kind of wanted to kind of close on are some features that patients or their caregivers or providers can keep in mind when managing these extrapulmonary cases that will hopefully allow patients to have better outcomes. So I think the first thing is access to experienced surgeons. So in general, as I've mentioned, for many of these extrapulmonary cases, surgery is really essential. And general consensus is that the earlier, the better. Though it is also important that the patient be started on some antibiotics before they go forward with surgery in order to increase the likelihood that surgery will be successful and the infection will be, surgically removed if possible. The surgical approach in these scenarios does tend to be almost akin to how we think about malignant tumors. So the wide margins around the infected area, ideally with sort of clean margins. So at the border of the resected tissue, that there is no remaining infection that's present. Of course, that's not always feasible, but that is something that we often strive for. Removal of foreign materials is essential. I've already kind of mentioned this, but in these prosthetic joint infections, it's very, 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 very difficult to eradicate infection if the original prosthesis remains in place because it has almost certainly been coated with these NTM organisms. And so you want to find a surgeon that sort of understands these principles, is generally just a very active surgeon or surgical practice, just sees a lot of patients in general, but ideally somebody that also understands the unique challenges of NTM infection specifically, because the surgical calculus does need to shift a little bit by comparison to other, for example, prosthetic joint infections with routine bacteria like Pseudomonas or Staph aureus. Safety monitoring, as I mentioned, is an important part of NTM treatment, be it pulmonary or extrapulmonary. So making sure that either at the site where you're getting most of your care or within the larger community that you're hooked up with audiologists, ophthalmologists versus a neuro-ophthalmologist, getting routine EKG monitoring. These are all very important to make sure that there's no permanent damage done from these long courses of antibiotics. Ideally, if possible, if the organism is able to be grown in culture, drug susceptibility testing is performed at baseline and then also performed serially over time, particularly if it's a situation where the infection is not responding like one would expect. Again, this is not always possible because the organism may not grow all that well, but if it does, it's extremely important to make sure that susceptibility testing is performed. Because, at least in the United States, we're often reaching for drugs that are hard to procure or that are newer on the market or that have these big price tags associated with them. I know, have benefited from having a dedicated pharmacist who works with us and helps to navigate some of these challenges. So if, in your disciplinary care of these extrapulmonary infections, have a choice between a few different sites or a few sites are managing your infection, it might be helpful to have some certain medications prescribed by whichever site has a sort of dedicated pharmacy infrastructure and support system. Similarly, if intravenous antibiotics are needed, outpatient parenteral antibiotic therapy or OPAT infrastructure is extremely beneficial. So this is pharmacy support, laboratory monitoring, regular follow-up, maintenance of the sterility of the line that's being used for infusing these antibiotics. All this is really important for patient safety and better outcomes. And then finally, I mentioned that clofazimine is often a drug that we use to treat these extrapulmonary cases. So trying to find a clinic where they have a standing multi-patient access program for clofazimine is also helpful. And it's often these larger tertiary referral centers which really kind of saves a local ID physician, for example, from going through the headache of having a single patient access program. So that's just another suggestion for how to manage this. So in closing, some final thoughts. Extrapulmonary infection can be isolated at the site of original inoculation or original surgery, or it can be disseminated throughout the body. there are certain conditions, medications, procedures that further increase the risk of extrapulmonary NTM infections. In general, treatment regimens are fairly similar to pulmonary NTM, but I would say the durations are the most kind of variable, as opposed to pulmonary, where we do have fairly clear guidelines that tell us how long folks need to be on treatment. Side effects, much like pulmonary NTM, are common, but experienced centers can help to navigate that and hopefully help patients tolerate the drugs a bit better and remain safer. And then just to underscore that identifying NTM infections, but particularly extrapulmonary NTM infections, requires a high clinical suspicion, and it requires getting the right culture, pathology, smear microscopy, ideally from multiple different tissue types. So free-flowing fluid that's thought to be infected, tissue that's resected and thought to be infected, that all sort of maximizes the chance of actually confirming this diagnosis when there's the right clinical suspicion. All right, and with that, I will stop and love to open it up for discussion.
Okay, great. We actually have a bunch of questions, so I will start by reading out. I'll just start reading them. Okay, the first one: is it safe to have cosmetic facial injections, Botox, Juvederm, etc.?
So my short answer would be yes. But my longer answer is that I would absolutely make certain that these types of procedures are done. Are done in an association with a larger kind of referral care center. So outpatient clinics that basically exist to be high throughput for these cosmetic procedures sometimes do not have the necessary sterility in place. So other things like Botox, whatnot, those generally are a little lower risk. The fat grafting procedures, which have become so common, Brazilian butt lift is one sort of a very common procedure that people are getting done in huge numbers at various places across the country. It's not an inherently problematic surgery, but it is problematic if it's done in one of these kind of hospital-based scenarios. So my short answer is yes, it is still fine to do those sorts of things. There are certain procedures that I would absolutely make sure, though, are done associated with a larger healthcare system.
Another question, sort of on a similar vein, regarding NTM infections from surgical procedures, does this include things like colonoscopies, bronchoscopies, etc.?
So thankfully, these kinds of infections from just other routine procedures and surgeries, they really do remain uncommon. And I highlighted some of these cosmetic procedures because, again, those tend to be done. Many people are having these procedures done in outpatient clinics without the sterility practices in place. But things like colonoscopies, bronchoscopies, I would not be worried at all about those introducing NTM infections. So again, those tend to be done in centers that are affiliated with hospitals that have very robust infection control practices in place. There is always a theoretical risk, but it is not, I would say, particularly high, unlike how it is for some of these cosmetic procedures that I mentioned.
Okay. A follow-up question to that: is it possible for an NTM-related infection in the GI tract to disseminate or aspirate into the lungs?
So I would say that there's two questions embedded in that question. So when we think about pulmonary NTM, we do think about reflux aspiration as a potential portal of entry. So I counsel my pulmonary NTM patients regularly about, are they having any reflux type symptoms? Are they aspirating? When they swallow, do things go down the wrong pipe? Because we all eat NTM, we all drink NTM every day. That's just part of the human experience. But if somebody is having reflux or aspiration episodes, that can serve as a way of NTM ending up in the lungs. So I think the aspiration part of your question, the answer is yes, but in my mind, that's not a dissemination. It's a direct inoculation that's going on. The risk of dissemination from the gut out into the bloodstream is not something that we commonly see. In patients who are profoundly immunosuppressed, so again, thinking about the person with HIV who's not been on antiretrovirals and has a CD4 count that's less than 50, the original source of their disseminated mycobacterial infection could be the lungs, it could be the gut, it can just be from any of the sites in the body. But in general, I would not say that the presence of an NTM species within the gut poses a great risk for dissemination, but it can be a way in which, if there's reflux happening, it could end up from the stomach, but directly into the lungs, not disseminating within the bloodstream. Hopefully that made sense.
We have a patient who's writing in. They have a history of disseminated NTM coloni. Is that how we pronounce it now? I'm not sure. Skin infection. So they are now getting worked up for recurrent infection. They have some painful nodules in the soft tissue in their upper legs and arms. Their original gross pathology on that noted it as lipomas. So far, there's a negative on the fungal, negative on anaerobic. It's been 7 weeks. They're still growing for aerobic. If somebody has a history of that kind of infection, and if the AFB smear was negative, but the patient had a history, would they try to grow those sort of samples out longer to see if something does come up?
So it's a great and complicated question. Usually by 8 weeks, if we're going to grow an NTM organism, it'll grow. So extending it past 8 weeks to 12 weeks, I don't think would dramatically increase the yield from that. There are certain mycobacterial subspecies that prefer warmer or colder growth temperatures. And so if the clinical suspicion for recurrent or persistent, mycobacterial infection is high, sometimes what the lab can do is, when the surgical specimens are collected, inoculate it into growth media, but incubate it at more than the typical number of conditions, and that can sometimes help facilitate growth. So the length of holding the culture, I don't think there'd be that much additional yield past 8 weeks, but there can be other things that are done to try to increase the yield a little bit. This could also be a situation in which PCR-based testing could help. That's not something that most labs have access to, but there are referral centers in the country where you can have surgical specimens sent. This would obviously have to be facilitated by providers. And they can basically look for small fragments of the mycobacterial DNA in that specimen to see if it's present. It's not the preferred means of diagnosis, because when that's the only technique that identifies the organism, you can't get drug susceptibility testing done. All you're saying is there's little bits of this or there's not. But that's another potential option if, like, traditional culture methods, smear microscopy, pathology haven't yielded an answer. Hopefully that answered that question, but it's a complicated one. So it sounds like a complicated case as well.
Yeah, that's a good question. There was a follow-up question for that regarding this and M. coloni. If it's in soft tissue and fatty soft tissue, are there certain characteristics associated with these kinds of infections that there are certain visible characteristics that you would look for?
Yeah, so I tried to underscore that there's not the always is the challenging part there. So I would say that there are sometimes certain features that are seen, but there's not always something. So the things that could be suggestive of it. So on imaging, it's sometimes non-specific, right? So this isn't your run-of-the-mill bacteria that's going to form this big, obvious abscess. It can sometimes be a little bit more subtle, like fat stranding or just general kind of signs of inflammation are sometimes all that's seen on CT scan. In terms of the tissue and the pathology, or the comments that a pathologist might make when looking at it, sometimes they can see acid-fast bacilli. So those are, mycobacteria that are lighting up on the special stain that helps to highlight mycobacterial organisms. So acid-fast bacilli should be looked for. And then granulomas are also a really common thing in NTM cases in general, be they in the lungs or elsewhere in the body. You can have non-caseating, caseating granulomas. Both of them could be suggestive of an NTM infection, but those are some of the things that you would see in a pathology kind of slide or specimen if there was an area of concern.
Okay. Somebody else wrote in they had an abscessus infection in their sphenoid sinus. They finally got rid of it with IV antibiotic therapy. They're wondering, are you seeing any infections in the sinuses? Are you seeing an increase in numbers in those kinds of infections?
So it's a great question. I mean, we certainly do see those at times. I wouldn't say that I've observed an increase in that, but it's also probably such a rare phenomenon that we're not able to readily kind of describe the epidemiology. I'm happy to sort of look through the literature and see if maybe like a specialized group like an otolaryngology or ENT group has tried to describe their, center's experience over the last decade, and that might give us a sense of whether or not, there's an uptick in that manifestation of extrapulmonary NTM as well. So I apologize, I don't know off the top of my head, but certainly has been described, and I'm happy to look through the literature and share with the group if that would be helpful.
Um, Here's an interesting question. Have there been studies on the incidence of extrapulmonary Pseudomonas aeruginosa infections? Interesting.
So Pseudomonas is a very common cause of infections. I mean, I was just on the inpatient consult last week, and we saw a number of different complex pseudomonal infections. Pseudomonas, pardon me, like NTM, we think of as kind of a water bug. And so that can sometimes serve as if a patient has a chronic wound and is soaking their affected limb in water, that can sometimes serve as a way that Pseudomonas would come in. But it's just a very common bacteria to cause postoperative infections, skin and soft tissue infections. We see it in some chronic non-healing wounds as a fairly common organism. So it's not, I wouldn't say it's disseminated in the way that we were talking about in today's talk, where in the setting of profound immunosuppression, local infection then disseminates, but it definitely causes many different types of infection. I mean, it causes pneumonia. It can cause bloodstream infections if the burden is high enough. So it's a very different kind of entity than NTM, but a very common bacteria that we see.
Okay. We have a couple of questions now, sort of related to the gut. So I'll start with the first one. Somebody's first they note some published research about abscessus infection found in stomachs, found on gastric biopsy. 92 of 129 were found to have that. This person has NTM lung disease, including abscessus, but they are also having severe gastric and intestinal symptoms for a long period of time. The doctors have been trying to figure out why. They don't know everything about it, so they're wondering, could it be that there's an infection in her gut that's causing that problem? And what could the doctors do to diagnose or rule out that possibility?
Yeah. So if I understand you correctly, it seems like Mycobacterium abscessus has been identified, in your gastrointestinal tract.
Not in this
Oh,
particular
in
patient,
this
but she was
NTM.
noting, yeah,
LD.
not in this
Okay.
particular patient, but she was noting that
Yeah.
that there's a study that found it in 92 of 129 patients. She has abscessus lung disease, but she's
Got
also
it.
having a lot of gastric symptoms for a long period of time, and her doctors can't quite figure it out.
Yeah.
So she's wondering like what can be done in diagnostically, I guess, to either rule it in or rule it out.
Yeah. So, so I guess two thoughts. So one is, to rule in or out the possibility that NTM is causing the gut issues, usually kind of routine diagnostic tests like an upper endoscopy, a colonoscopy with biopsy, looking for pathology, sending mycobacterial cultures. But specifically, because again, these are organisms that we eat all the time, just because it's identified in the gastrointestinal tract doesn't always mean that it's pathogenic, that it's actually causing, local invasive disease that would need treatment, specifically thinking within the GI tract. Things that might make us think actually it is causing a problem in the GI tract would be if on biopsy, again, they found evidence of granulomas. That suggests that there's, actual inflammation, involvement of the gut tissue. So that's kind of in terms of like, could the NTM be contributing to the GI issues? But for the other part about the NTM lung disease, and the role of the gut in that, I mean, it's sort of as I mentioned before, I think it's a very important part of how we manage NTM pulmonary disease is thinking about the gut, thinking about gut transit, thinking about if there's anything operative or non-operative, that can be done to facilitate, smooth transit of all of our, gastrointestinal contents through the system without refluxing up, without aspirating into the lungs. So two, I guess, related but separate questions. Hopefully I've given some guidance on those two.
Yeah, so we've actually had another question sort of in the same vein, somebody who has a diagnosis of Crohn's disease. They went to get a consult for NTM lung disease and bronchiectasis, and they got a second opinion, and the GI at the center that they went to thinks that they may have disseminated NTM in their terminal ileum instead of Crohn's disease. So would the diagnostic process be similar in terms of looking for that, granuloma and that sort of inflammatory activity?
Yes, it's tough though, because Crohn's can also cause, some granulomas to form. So it is difficult at times to disentangle those two entities. I think things that would suggest the Crohn's, or sorry, that an NTM infection within the gut is more contributory than the Crohn's would be if on medication for Crohn's, the disease is getting worse. Because again, many of the medications we use for Crohn's can be immunosuppressive. And so if you're on a medicine that should be making the Crohn's better by weakening the immune system, and in fact, the disease is getting much, much more active, that does, raise some concern about there actually being an underlying infection, be it NTM or otherwise. Yeah.
Okay. Is there a correlation between defective Th1 cells and susceptibility to mycobacterial infections?
Yeah. So in general, my understanding is that T helper cells, the Th1 cells, are protective against NTM infection. So that potentially, a Th1 deficiency could end up, making one more susceptible to NTM infections. Yes.
Okay. We have somebody, they have chronic lymphocytic leukemia, hypogammaglobulinemia, and they've been on IVIG for 11 years. They have MAC. They have a recent CT scan that's showing some swollen lymph nodes. What would be the diagnostic process to figure out if it's the CLL or if it's a MAC infection in the lymph nodes?
Yeah. So the process would probably have to entail biopsy. So again, if a biopsy could be safely performed of one of those lymph nodes, there would be some signs on pathology that would help, try and disentangle, is this CLL versus is this MAC. Additionally, if it could be sent for culture and it grows MAC, that also helps you out. I will just say that it is tough. I have a patient where we're similar kind of issues that we're grappling with. We do sometimes see in pulmonary NTM, just pulmonary NTM, that there is some lymph node enlargement in the area. And it's not, I wouldn't necessarily say that that's indicative of dissemination outside of the lungs. Often it's just that those lymph nodes are enlarged because the immune system, that's taking care of that part of your body is really revved up trying to fight this infection. So just because there are enlarged lymph nodes doesn't always mean that it's spread of the NTM infection. It can more be a very appropriate immunologic response to that local infection. So, but pathology is what would help disentangle that question.
Okay. We have a pulmonary NTM patient that's recently been diagnosed with, and I don't know if I'm going to butcher this or not, mild arachnoiditis in the L5, L4 lumbar area. So I guess in the spine. She's not sure if she should, follow or pursue further testing to determine if it's, caused by an NTM infection in that area, if it's like a disseminated NTM infection.
That's a tough one.
Do we know of any relation between an arachnoiditis, I guess, and NTM infection?
Yeah, I mean, so I'm sure it's been described, but as I think that the writer was alluding to, this is not common. So I honestly, that's just off the top of my head. I don't know the answer to that.
Okay.
And because the area we're talking about, sometimes biopsies can carry with them, some significant risks. So I apologize. I don't want to feel like I'm kind of going and maybe speculating a little bit too much about some of these very complicated, very excellent questions. I would say that this is something that definitely should be discussed with an ID provider. Yeah.
Okay. Yeah, that makes sense. Somebody's asking if you can speak a little more about the iris slide. I'm not sure if they have a specific question, but I guess um, maybe I don't know if maybe you want if there's anything else that you want to add about the iris slide, or if we need to have a other presentation about iris. I'm not sure how much,
Um,
you know.
Yeah, I mean, I sort of just threw it in there because I think it's interesting. And again, it's
Yeah.
mostly well described for people with HIV who are not on antiretrovirals. It's an incredibly well described phenomenon, now for many decades since the beginning of the epidemic. But it's just something that we consider when somebody does have a very weakened immune system, is on treatment for an infection. Here we're talking about NTM, but it can be other infections as well. And despite the bacteria seeming to go away, they are nonetheless having more symptoms. And so I just think it's something worth kind of noting if you were to happen to fall into that, fairly narrow category of somebody who's on treatment for an infection and is actually having their immune system get stronger over time, that could be something that might explain paradoxical worsening of some symptoms despite killing the bacteria, like all other signs pointing to the bacteria being killed. So if there's specific questions, I'm happy to answer those. Yeah, about the iris slide.
If somebody has, I guess, MAC, or they're asking if we have MAC, are we susceptible to having extrapulmonary NTM? I guess if they're asking if they have pulmonary MAC.
Yeah. So the short answer is no. So again, I tried to, and I anticipated that this would be a concern from this audience. It's a very appropriate concern, but by and large, the vast majority of people who have pulmonary MAC are not at increased susceptibility to extrapulmonary NTM infections. There are specific conditions where people are more susceptible in general to these NTM infections, but by and large, pulmonary infections stay in the lungs. People who are susceptible to pulmonary infections really only are at risk for those, not the extrapulmonary version.
Okay. Do you have any experience with rapid diagnostics in NTM disease, like the CM direct line probe assay from Bruker-Hain or the Roche Cobas assay for M. avium complex?
So I'm not a diagnostician. I work closely with our, AFB lab at Hopkins. I know that we've recently been changing the diagnostic tools that we have in-house to give more rapid answers. So yes, we did historically use the line probe assay. We're now doing more kind of molecular, probes to give us an answer down to the subspecies level and in more a rapid time. So, but I don't have like a, comparator thoughts about the relative, strength of these different diagnostic tests that are out there. But I will just say, I think one point I intended to make but didn't is that, for these extrapulmonary cases, for pulmonary cases, of course, we want to have the data as quickly as possible because it helps us as clinicians, it helps patients. But often with pulmonary infections, it isn't urgent, right? These are infections that take months, if not years to come on, take months, if not years to go away. For these extrapulmonary cases, sometimes it really is urgent. And so in terms of these novel diagnostic tests that are coming online, I really think that the extrapulmonary cases is where it's going to be most transformative, because if we could find out in, 48, 72 hours, the subspecies and a sense of drug susceptibility profile based on some of these genetic markers, that could really make a huge difference for that extrapulmonary patient who's got, a totally uncontrolled, bloodstream infection that's going to their brain. So yes.
So somebody's asking if they have a history of NTM and mild bronchiectasis, should they not take cyclosporin for a chronic painful bladder issue? They're asking because it is one of the few tools in the bladder pain toolbox. So I guess that's actually a very good question.
So it's a good question. I wouldn't say that it should be avoided, as a matter of course. I think it is just worth kind of talking through with your different teams, particularly your infectious disease team, about that, relative risk and what kind of monitoring plan we should be in place. I have tons of patients who have pulmonary NTM who have to go on immunosuppressive drugs, right? They have cancer, they have a progressive rheumatologic disease, right? And so this is something that we encounter, not infrequently. And we don't tell patients not to take these other drugs that they need for their other medical conditions. But I think it's important to have kind of a risk-benefit discussion. And like I said, more kind of a monitoring plan. Like, let's say standardly you would get a CT scan of your lungs once a year. Maybe as you're getting started on cyclosporin, you might check in a little bit more frequently with your lung team, and maybe you'd get a CT after 6 months, you know, something like that. So I can't say for certain, but that would be my guidance, is to have a plan in place, talk with an ID doc before you start the cyclosporin, but I wouldn't avoid it if it would be helpful for the bladder issues.
Here's a great question. Where is Kevin Winthrop when we need him? Are pedicures a source of infection? I think the short
Yes.
answer is yeah.
Yes, yes, they are. Yes. And so there's a number of different cases of like furunculitis caused by NTM after patients have gone to the nail salon. One thing that seems to be associated is shaving before you go. So don't do that, because that just opens up all the pores and allows these mycobacteria that might be hanging out in the water to jump in a little bit more easily.
Yeah,
So
I was told not to
yes.
shave for at least like 3 days before I go for a pedicure,
Yeah.
at least 3 days. And, the pedicure infections is actually how I came to start calling Kevin Winthrop Dr. Pedicure. So there you go. How long after surgery would an NTM infection start to show?
Yeah, great question. That was one of the many slides I took out. So big range, but it can be weeks to months. So I would say somewhere along that. So weeks to months. But it's not as fast onset or as aggressive, right, as a typical bacterial infection, which is again why the, clinical suspicion needs to be there in order to send the right tests.
Okay. Do you typically see an immune response alongside extrapulmonary NTM? In other words, do other patients have joint pain and issues with their joints when they have extrapulmonary NTM? They had a severe joint pain with their disseminated infection, and they're wondering if that's common.
Yeah, great question. So I have had some patients that did seem to have some sort of polyarthralgia, just general joint pain while they were kind of in the thick of that early infection, just feeling really, really sick. Obviously, also our drugs sometimes can cause a whole bunch of different side effects, including some joint pain. So hard to tease out, what's the primary disease versus what is drug induced. But absolutely, I've seen some people just when they first come in, even if it's never in the bloodstream and it's just in the skin and soft tissue, just having this really profound immune response. Their immune systems are just so active because many times these patients, again, are immunologically normal. So they are able to mount this very robust immune response.
Okay. So somebody was asking about the corticosteroid therapy increasing the risk of pulmonary NTM. Does it, they're a little confused and they're asking,
Yeah.
does it increase the risk of it and of pulmonary becoming extrapulmonary?
So no, and I want to circle back to the first half of your comment. So I listed steroids kind of in a long list of immunosuppressing drugs that could increase the risk. But by and large, use of systemic corticosteroids is most associated with pulmonary NTM, just steroids. It's more associated with pulmonary NTM than it is with extrapulmonary NTM. And that's
Got it.
probably because if you have a chronic lung disease, maybe some COPD, emphysema, asthma, and you're taking various steroids for that underlying inflammatory lung disease, that's also going to be where you're most likely to get an infection in the first place. So yeah, just short courses of oral corticosteroids, I would not be concerned about putting you at risk for disseminated infection at all, at all. Inhaled corticosteroids, also no evidence that I'm aware of that would suggest it would lower that, very strong local immune kind of barrier that your lungs are, and that it would put you at risk for disseminated infection. There are some data inhaled corticosteroids might be associated with increased risk of pulmonary NTM, which is why if we don't need them, we don't use them. But we also have to use them all the time, and many patients do not end up developing any type of lung infection, including NTM, but certainly no association with extrapulmonary NTM.
Okay. Is there any new data on the association between Mycobacterium avium subspecies paratuberculosis with inflammatory bowel disease? And do you think IBD cases might benefit from MAC treatment? I guess that would depend on whether they have a MAC infection in there.
Yeah, it's sort of like the Crohn's discussion before. It would just depend on if there was a true infection there. There's been some speculation about NTM infections serving as like triggers for certain inflammatory conditions, but again, the treatment differs so much between these two disease entities, and we know that people with IBD, do get better on immunosuppressive drugs, right, which really should not make an underlying NTM infection better. So a little yeah, I think a little complicated to disentangle, but I would not, recommend routinely that patients with IBD, get MAC treatment.
Okay, I just want to skip down a little because somebody was following up on their statement. They about their joint pain. They are clarifying that they have disseminated extrapulmonary NTM abscessus, but their symptoms included severe joint pain in multiple joints, alongside of the granulomas, nodules, lesions, and open wounds. The NTM was also found in the synovial fluid from the knee, but the inflammation was systemic.
Hmm.
Interesting.
Wow. Okay, so I mean, in that case, that seems like it's above and beyond just what was inflammatory, response, and or drug induced. It seemed like, yeah, actual a disseminated infection. And obviously,
Yeah.
without knowing your whole story, I hope that there was lots of kind of workup for why the infection might have been so widespread.
So now we have a couple questions about dental procedures, cleanings, extractions, periodontal surgery, dental implants, root canals, etc. Can those cause soft tissue infections in the lymph glands or local tissue? And how can patients sort of protect themselves? I know that pulmonary patients have some concerns when they go to the dentist, particularly when it has to deal with water being sprayed. And I know a number of patients bring their own water to the dentist to, use for rinsing and so forth. But, can you talk a little bit about the association
Yeah.
between dental clinics and dental procedures and NTM?
Um, so I don't consider that a particularly common form of extrapulmonary NTM infections, though it can happen. And again, I think one point to reiterate is that for patients with NTM pulmonary disease who are trying to make sure that they're taking other mitigation strategies in other domains of their lives, there's not an increased risk for extrapulmonary NTM, and that includes, dental or post-surgical, right? So like the risk there would be similar to the rest of the population, most likely. So this really, for most patients with pulmonary NTM, this is a site-specific risk. So I just think that's one important part to kind of underscore. So the risk of somebody with NTM PD developing a dental NTM infection after a procedure would be similar to kind of the general population. So there's not routine kind of precautions that I recommend my patients with NTM pulmonary disease take when they go for dental procedures and things like that. So, I don't recommend that they bring their own water, whatnot. I just sort of recommend standard precautions. So,
When it comes to, infections from dental procedures, in like skin and soft tissue, would that be more a case of either having, an immune deficiency or some kind of direct inoculation?
So it would be immunodeficiency or just such a massive burden of NTM that is introduced at that site that it exceeds, what your body's able to manage, right? So again, it's almost like somebody who's got, just a totally normal immune system, no history of any infections, and underwent, I had a procedure that underwent a back surgery and ended up having an NTM infection there, but it was because there was obviously NTM introduced during surgery, and in the setting of all this disruption of the immune, protective space, they developed this infection. So, yeah.
Can swallowing the mucus that they have caused by bronchiectasis and MAC, can that affect their gut?
Hmm. That's a new one for me. Only if you're then aspirating what you just swallowed and it ends back up in your lungs. So I would say, as long as you're coughing it out, if you swallow it, I mean, it's not as great as if it's totally out of your body, but I wouldn't say that would dramatically increase your risk of then, try to cough it out. But unless you're aspirating back up, having it in your stomach per se shouldn't be putting you at more risk.
Okay. We have an interesting case here. Somebody had a skin biopsy that came back as granulomatomas, dermatitis. I think I've said that right. And they suggested how to work up, including a chest CT, and ultimately they were diagnosed with MAI in the lungs. Um, they, they don't know if that means that the MAI in the lungs came first and the granuloma came as a reaction, or if there's, another NTM species in the skin and maybe it just wasn't tested, and they don't know if they should be looking for something else.
Yeah, it's a great question. Yeah, I had a patient that was sort of grappling with the same issue. So granulomatous inflammation is a somewhat non-specific finding on, a skin biopsy. And so things that would maybe change it if there were like caseating granulomas in the pathology, then that to me is somewhat more suggestive of there being an active, disseminated inflammatory or infectious process. Granulomatous inflammation is a broader kind of terminology. And so it's not as strongly supportive of this being, an active infection within the skin. So I would say it doesn't necessarily mean that this was two sites of infection, that it was disseminated as the person was asking. We do sometimes see that in the setting of, lung infection, the body is just kind of flipped into this very revved up pro-inflammatory state, and there can be just other kind of inflammatory things that unfold, including sometimes some skin changes, but it's not the infection per se invading into the skin. So I apologize, I can't say for certain in that case. Again, I would say, consulting with ID, seeing an immunologist wouldn't be a bad idea, just for a kind of thoughtful workup and review of the data to date, even if it's just a once-off appointment. I really love working with our immunologists here in these cases, and they usually have very good insight. So,
How do you test for defective T cells?
So that is probably also deserves its own kind of talk. In my clinic as an ID doc, there's a kind of cursory immunologic workup that I do on most patients. So looking for immunoglobulin levels, looking at lymphocyte subsets. Sometimes I'll also get titers for vaccine response. So if somebody's been vaccinated against SARS-CoV-2, I might get SARS-CoV-2 titers or pneumococcal titers to see if they've mounted an appropriate response to the pneumococcus vaccine. And once I kind of do that initial workup, depending on the broader picture or exactly what my concerns are, then I might again refer to an immunologist, and they can do a much broader, much more thoughtful kind of exploration of all the different parts of the immune system that might be dysfunctional or underfunctioning, and see if there's anything that can be done to change that individual's immunologic risk.
Another question, can NTM invade the spine or brain?
Yes. Yes, so I showed a couple slides of an NTM infection that had gone into the epidural space, that had caused spinal bone infection, that had gone into the brain and the cerebrospinal fluid. So in a word, yes.
Can the immune suppression caused by IV steroids put someone at even more risk for an NTM infection?
It depends on the kind of duration. So again, we have patients that are on far more powerful immunosuppression than steroids, and still we say that it's okay to give those because they need those for their other conditions. And we do not then immediately worry that their NTM lung disease is then going to spread throughout the body. That's really only in very, very potent, very long courses of immunosuppression that would lower the barrier to that extent. So I can't comment definitively, but it's again, ID doc tends to be pretty thoughtful about that risk.
Okay, I think we have a couple of questions to wrap it up. Can a patient be misdiagnosed with M. columbiens? They had to show up on a sputum culture, and they're still waiting for the results of bronchoscopy. They don't have HIV. The doctors were stumped. They haven't been out of the country.
Yeah.
You're not really sure how it came
Yeah.
about.
So these mycobacterial species, right, they're everywhere, even ones that we think have a more kind of specific geographic niche, that are more common in certain parts of the world. They really are everywhere, they're being brought around. And so like with any NTM that's identified from in the sputum, you need multiple sputa growing the same organism and suggestive symptoms and a supportive CAT scan in order to say this is a true pathogen that would benefit from treatment. So just because some uncommon NTM was found once does not necessarily mean that it reflects a real pathogen in your case that needs to be treated, but you would need to get more data and again meet those other diagnostic criteria.
Okay. Can you comment a little more about like biofilms, and NTM infection? You had talked about biofilms on, implant hardwares like, prosthetic joints and so forth, and how when there's NTM infection associated with that, you have to debride, you have to take out the hardware, you have to clear the infection, and then put the hardware back in because the NTMs like to grow biofilms on those prosthetics, and implants. Um, is there something similar that's going on, like maybe if there's like a bone infection with NTM or something? Is there a biofilm issue there, or is that something completely different having to do more with?
Yeah, so prosthetic material is particularly problematic in terms of the biofilm formation, but it can also happen in with just your own innate native tissues. So, I mean, people speculate that's one of the reasons why certain NTM infections may be so hard to clear from the lungs is because of biofilm formation. So it's more of a problem that it becomes more recalcitrant when there is prosthetic material. But I think it is just a phenomenon with NTM in general, is how they, kind of form these biofilms, and it's difficult for the antibiotics to penetrate in there and eradicate the infection.
Okay, somebody's saying they're going to have an MRI of the brain and spine, and they want to know, does it show like an NTM infection? Is that part of the diagnostic, an MRI?
Yes, in the right clinical scenario, an MRI of the brain and spine, would show signs of infection. But of course, I mean, there's not specific things on an MRI of the brain and spine that would just scream out, oh, this is clearly an NTM infection. An epidural abscess is an epidural abscess, right? You're not going to know which bacteria is causing it until you get in there and get some samples or get pathology and all the rest. So, yeah.
And we have a final comment, and I think this actually may be a project for us to work on, Elisa. Somebody is asking, do we have a list of suggested immunologists who are well-versed in NTM? We don't, and that might be the next step to take with our physician referral list now that we've had pulmonary and ID put on it. She wanted to know if you have any recommendations for immunologists. Catherine, I'm going to suggest that you reach out to us directly. Let us know where you're located. And we will try to find a good immunologist to recommend for you. So thank you, everybody. Thank you very much for attending. This was great. This was very informative. Everybody seemed to be very excited. This is helpful. Again, if you have extrapulmonary NTM, if you are the caregiver or a family member of a patient with extrapulmonary NTM, if you are a physician caring for extrapulmonary NTM patients, we are having a support group meeting tomorrow. Email us at ntmmail@ntminfo.org for the information. And, please, if you have pulmonary NTM, if you're treating pulmonary NTM patients, we have support groups for you as well. So please make sure you reach out to us. We are absolutely here to support you. And thank you, everybody. Thank you for your support during World NTM Awareness. We really appreciate it. Elisa, thank you so much for bringing World NTM Awareness to a great close for us. We really appreciate it.
My pleasure. Thanks for all the great questions.
Thanks, everybody.